I don't know, but we'll introduce it again. Holding slide and some music. We'll certainly introduce it. Thanks for reminding me.
Afternoon, colleagues. It's exactly 2. Do we want to give another 2 minutes, Mbali, or do you think we can start?
I think maybe let's give it another 2 minutes, and
Okay.
then we can start.
Okay.
Thanks, Anita.
No problem. Okay, good afternoon, colleagues, and welcome to our Friday session. Mbali, I'm not going to waste any more time and hand over to you.
Thanks, Anita, and good afternoon to everybody that has joined us for yet another Friday webinar. As Anita has indicated, my name is Mbali Buthelezi, and I'm the current acting head of the Public Expenditure and Policy Analysis Unit in GTAC, and that's where we do spending reviews and other work related to personnel analysis and government. So for those that don't necessarily know what spending reviews are and what we do, so spending reviews really are about conducting in-depth assessments of current public expenditure, and it really helps us to identify opportunities to reduce sometimes, and also in some instances, redirect spending from low priority, inefficient or ineffective spending areas. Spending reviews are an important public financial management tool because they can help create fiscal space, which can then be used to fund new priorities, address emerging spending pressures, or reduce debt. But obviously that requires departments or the affected party to implement the recommendations that come out from the spending reviews. Because if they're used as an integral tool for budget planning, they can help ensure that budget decisions are informed by program performance, and also that spending remains aligned with changing priorities of the government and its citizens. We're all aware of the current fiscal constraints we're facing, so really if spending reviews can be used integrally rather as a tool for budget planning, they really can help ensure aid and alleviate some of the fiscal pressures faced by government currently. And moving on to today's webinar specifically, today's webinar is a spending review that was done on the HPV vaccine program. So HPV is the human papillomavirus vaccine, and 3 spending reviews have been carried out since the implementation of the program. So today's spending review really summarizes the findings of those 3 spending reviews, but also it reviews existing and current performance and other information on the program that is published maybe in the conditional grant frameworks, the conditional grant reports, and part of the spending review also includes a costing that was undertaken on the HPV vaccine rollout and the results of the costing. There's also some brief recommendations that Jonathan will take us through provided regarding the way forward. The person that will be presenting on this HPV spending review is Jonathan Carter. Jonathan Carter is an LTA in GTAC. He's been really working with us, I think, for over a decade now. He's been a part of the spending reviews, doing technical spending reviews, but also providing training to government officials on the spending review methodology. Without wasting any more time, I'm going to hand over to Jonathan to take us through the spending review. And Jonathan, over to you. Thank you. You're on mute.
I've clicked all the buttons except mute. So, cool. I hope my screen is on the correct screen. You can see.
Yes, we can see it.
Yeah, I'm just going to turn the camera off because you don't want to see my face. Cool. Thanks for that introduction, Mbali. Good afternoon to everyone who's on the call. I'm quite surprised by the number that are here. I'll get straight into the presentation and then we can to make more time for discussion at the end. This is the what's going on. Why is this not changing? Okay, there we go. Here's the agenda for today. I'll introduce you to the spending review briefly, then take you through, discuss the rationale for the HPV program, look at the process flow of the vaccination program, talk briefly about the evolution of the conditional grant, although I'm not sure evolution is the right word, just changes that happen from year to year as a result of events in the conditional grant. And then look at the costing and some concluding points and thoughts on the way forward with HPV. So as Mbali said, this is a review of spending reviews. It was completed early last year. We did a costing model of the program to compare the costs, cost estimates to the allocations of the HPV conditional grant. There were 3 expenditure reviews by Karusha at a national level, and then Sahunelo and Raymond did in Northern Cape and Gauteng, respectively. If a spoiler alert, but in short, the program appears to be achieving its objectives, and I'll define that more clearly as we go through the presentation. We didn't find any obvious opportunities for or the need to reduce costs in the program. It's not a massive program, and there are potentially quite substantial cost savings, human life cost savings that or prevention and death that it causes. Compared to those benefits, the costs are quite minimal. And then a key recommendation that we suggested is give consideration to ending the conditional grant and phasing it into the equitable share. But we will come back to that later. So why do we need this programs for HPV? It's HPV, I've actually got it written here anyway, the human papillomavirus virus. I do have it written somewhere else on these slides. It's a sexually transmitted infection that causes cancer, cervical cancer, and cancers of the vulva, vagina, penis, anus, and throat. It's more, it generally presents itself in women rather than men, although men can carry the virus. But the viruses, the cancers that are caused by HPV generally take decades to develop. So it can be contracted in teenage years or even earlier than that, and then sit around your body and only start to manifest itself in a cancer in late 30s, early 40s. So that can be prevented through a vaccine. And it's generally accepted that community spread of HPV can be stopped if 80% of girls are immunized before they become sexually active. The HPV program has been a partnership between health and education sectors. Health have taken responsibility for the conditional grant and managing the procurement and distribution of vaccines, and the management of staff that implement the program. But the program has been rolled out in public schools. It was targeted at girls over the age of 9 in grade 5. The age group has changed in the last few years, and we'll go into that in a bit more detail. So this is the process flow of the vaccination program. Mbali earlier sort of emphasized that this was part of the spending review methodology, or this review is from a spending review. And one of the steps in the methodology is to do a detailed process flow. So this comes from the spending reviews. Provincial departments report the number of grade 5 learners to the national department. The national department reports those grade 5 learners to the National Department of Health. And then Department of Health uses those numbers to estimate vaccine stock that's required per province, and places that order with the suppliers. And then the vaccine supplier will put out, will hold that stock, or order that stock internationally, wherever it comes from. And provinces will place orders with the vaccine supplier, and provinces now pay directly to the vaccine supplier for the vaccines. And then the vaccines will be distributed according to a schedule in the HPV plan to provincial depots, and the vaccine either goes to provincial health facilities or to provincial health, or to the provincial HPV teams, or the HPV teams can collect them from the provincial health facilities, and the HPV teams take those vaccines to schools, and they jab them into girls at the schools, and that's how the program works. So the history of the conditional grant: it was first funded through the National Health Insurance grant, which is an indirect grant. It was a component of the National Health Insurance grant, funded off Program 3 of the National Department's budget. And then provinces took responsibility for distributing the vaccines and managing the program. That arrangement lasted for 2 years, and then a direct grant for what we call the HPV vaccine grant was introduced for 2 years, which is a normal conditional grant was managed by provinces. In 2021, that HPV vaccine became a component, one of 8 components of the HIV, TB, malaria, and community outreach grant. In 2019-20, the department indicated that in the following year, the grant would no longer be provided to grade 4, or no longer target grade 4 girls. It would target grade 5 girls. So from 2021, it was switched to, well, the target were grade 5 girls, age 9 and above, that would be vaccinated for HPV. There's some details on the slide I'm going to come back to later. So since 2022-23, it's the HPV program has been funded through the district health component of the district health programs grant. So there's the 2 sort of aspects to the district health programs grant, and then with what in the wording in Divisional Revenue Act are components, and then within those 2 components there are sub-components of the district health programs grant, and that HPV now sits in the district health component of that grant. And the HPV allocations are shown in the grant framework. And why is my computer being funny? Sorry. So the HPV, the allocations per province are shown in the framework. And there's a requirement that these allocations are linked to an objective on BAS. So this is the framework for the conditional grant framework for the district health program grant. I've just taken a picture of the relevant section for HPV vaccine from that grant framework for this year, for 2023-24. So provinces have been reporting on the expenditure against HPV for more than just the last 2 years that this has been required by the conditional grant. So you can pick up expenditures in BAS. This pulled this out earlier today, just looking for HPV using the objective lowest level in the health budgets of all the provinces. These numbers quite closely follow the numbers you saw in the previous slide for allocations per province. I don't know why Northern Cape and Mpumalanga are not reporting against this objective in BAS, but the other 7 provinces are. It just illustrates how easy it can be to track expenditures against conditional grants if provinces reported correctly. But yeah, it's the point of this is the expenditure information is there and it's pretty easy to find, and provinces appear to be implementing a grant as required. So performance of the grant since 2014 has been fairly good. There's 1 year in 2016-17 where it was slightly lower than normal, but most years the target of 80 or above 80 has been reached. Last year, in the conditional grant framework for 23-24, it's showing again that the target of 80% has been reached as the target in the grant. There's variation across provinces, but at a national level, the target of 80% of grade 5 schoolgirls that are age 9 and above. My reading of this data that it is a little bit inconsistent. To me, it looks like that the targets are being reached. I'm not sure why it's saying here that 94% of grade 5 schoolgirls aged 9 and above have been vaccinated when it's got a different number there. But that's what the grant framework is saying, and I will assume that there's truth in those numbers. So, in a nutshell, it's hitting the targets. The grant has been spent, so it's working. Okay, that level of expenditure of 76.2% expenditure was achieved during COVID, and the targets were reached during COVID. So even as a result of disruption from COVID during 2021, the program went on and reached its targets, which shows quite a high level commitment to the program. So in conditional grant frameworks, the departments are required to state why the grant is not in the equitable share. And the reason stated in the last 2 years why it's not in the equitable shares, it's cervical cancer is a high national priority, requires uniform implementation to achieve the minimum coverage of 80% and have the desired impact of significantly reducing incidences of cervical cancer. So that's why the grant, why that funding does not go through the equitable share but is protected in a conditional grant, is to ensure that that minimum coverage of 80% is achieved, and it is achieving that. The purpose of the grant, according to the grant framework, and just looking at, you have to take out the little bullet point with respect to the HPV component of the district health grant. Is the purpose of the grant is to enable the health sector prevent cervical cancer by making available HPV vaccinations for grade 5 schoolgirls in all public and special schools, and progressive integration of HPV into the integrated school health program. So it's only provided in public schools and special schools. It's not, government doesn't extend this program to private schools. And the objective long-term thinking, I think, with the program is to integrate it into the school health program, and possibly phase it into the provincial equitable share, the funding into the provincial equitable share. So it's managed as part of normal health budgets. In previous time, or when we presented this for the first time, we asked what more needs to be achieved for this to be integrated into the school health program. I know there's someone in the audience that will be able to respond to this point, that it will help if the integrated school health program is updated. I believe that will be happening later this year, and we can look at how this program can be integrated as part of that school health program. The next few slides, I'm going to talk through numbers from that analyzed performance of the grant. So here in the orange bar chart, we are showing the number of girls in public schools that are now 80% of these are targeted for the vaccine. So in 2018-19 and 2019-20, the program targeted grade 4 girls, and then it changed to targeting grade 5 girls. And there's a significant drop in the number of girls between grade 4 and grade 5, which I can't explain to you. And then since then, that number has dropped each year, but the allocation to the grant has remained quite stable or grown slightly. And the cost of not the cost, but the allocation per girl, if you work it out as on a grant per girl basis, that has grown each year as well. So the line charts, you need to look on the right hand side. Sorry, the lines, the axis is on the right hand side, the bar chart axis is over here. That just gives you a very high level snapshot of the numbers. This slide is comparing the cost of the vaccine to the total value of the HPV grant. So it's saying here, for instance, in 2018-19 in Eastern Cape, 50% of their grant allocation should have been spent on the vaccine. The other 48% or whatever it is here was for non-vaccine expenditures, non-vaccine costs in the grant. So that number's been, that ratio has stayed relatively constant across the years. Each of these bar charts, different color bar charts, is a different year. And all provinces are sort of somewhere in a range. This low level in 2019-20 of sort of 45% up to about 67%. Most of the provinces are in that range. Gauteng is outside of that, I think, largely because the formula of the conditional grant takes into account that there's a high density of schools in Gauteng, and therefore the vaccine costs as part of the program are lower in Gauteng than they are in the other provinces. But yeah, that's the only real story to tell about that. It's fairly normal looking numbers, I think. Yeah, and the grant is working, it's been allocated correctly. This shows you the average size of the of school, average number of girls per school. It's ordered in that level from the smallest schools to highest schools in Gauteng, and then compares the average grant per child to that. And generally, it's fairly ordered. It goes from the highest to lowest cost of or allocation of grant per child, average grant over the years. So there are one or two outliers, but that's if you look at those provinces, Northern Cape and Northwest, where the district or the spread of schools, the distances between schools might be quite different to other areas. But it's, to me, it looks fairly normal that this indirect relationship between the two. Nothing to be alarmed about by the allocation criteria used for the grant, or the costs of the grant. So to explore those numbers further, interrogate them deeper, we did a costing. The core elements of the costing, we costed the cost of a team. So there's a HPV team that, and I'll show you the composition of the team at the moment. And we estimated the number of full-time equivalents. We estimated the cost of transport, and then we also estimated the cost of vaccines, which was the easiest part, the number of girls to be vaccinated times by the number of doses they receive. So the number of the transport costs and the cost of the team are sort of related because your FTEs are affected by the time that people spend traveling. We linked all of this to the number of schools per district, the size of the district, the number of girls per school. We used an average for each province. The DBE data we used was the school's reality, and then we also used the school's masters list to calculate the number of girls per school. So the school's atlas was used to calculate, or we pulled the district sizes from the 2013 schools atlas to compare that to schools data from 2022 or 2021, and there have been some changes since in district boundaries and so on between 2013 and 2021 or 2022. So getting that right needed some alignment. So there may be some schools that you had to guess which district they're in. But if there's anyone from DBE, it would be useful if you updated the schools atlas for these kind of analyses. So this is the costing in one picture, but there is a lot of information in the cost model. And it's always difficult with costing to know where to start and know where to end, because all these things link to each other. But I'll take you through all parts of this and try to confuse you as much as possible. There are two types of training workshops that are part of the costing. We assume that all short-term appointments attend training, so they need to be trained on how to implement administer the HPV vaccine. We set up workshops for 30 people, or estimate the cost of a workshop for 30 people, and then based on the number of FTEs required, we could calculate the number of workshops that were needed. We say that the vaccination team travel by car to all the schools in the district. These little black things are meant to be schools, and we use the distance between schools and an assumed speed at which people can travel in each district to calculate the travel time that for teams to be able to travel and visit each school during the campaign. There was a materials cost of 250 Rand per school per campaign, but these assumptions around travel time were added to time estimates of estimates of the amount of time that the team needs to spend at each school. So we had a total for the time at schools, and that's 120 minutes per school multiplied by the number of schools per district. And we added that to the travel time, which is a function of all these variables. This part is quite complicated. Initially, I thought it would be easy to do, but the more I went into it, the more complicated it became, but it remained a part of the costings. Those two are used to calculate the total time needed to get to all schools in a district, plus 120 minutes per school, gives us a total time, and then we divide that by the number of days that members of the HPV team or the integrated school health team work in a year, and that gives us the full-time equivalents, and we could use the full-time equivalents, multiply that by the salaries to calculate the cost of employees, or total salary costs. The vaccines, we used an amount of 330 Rand plus consumables of 5 Rand. So the consumables are, the syringes and wipes. You might have to have the sort of disposable tablecloths in some places. And that was estimated by 80% of girls in grade 5s in public schools. And that data is taken from EMAS. That's the costing model in one picture, but each component of these, I can do a half-a-day workshop on each part of this. So this slide is showing you the total cost estimates from the costing compared to the grants. So the orange are the cost estimates from the costing model, what we estimated should have been allocated per province for implementing the HPV program. And the blue is what they actually got from the HPV grant last year. And you can see it's very close. There are one or two provinces where there's quite a big difference proportionally. I think the Eastern Cape and Northern Cape there's quite a big difference there. And the question is whether the model overestimates the non-vaccine costs. When I say the non-vaccine costs, it's the costs around sort of travel, the team that needs to be there, maybe the consumable costs and the travel costs. Those are your non-vaccine costs. So we're asking whether the model overestimates those or whether the grant criteria underestimates those. That's a question that can be explored with the costing like this. Here we are able to use the model to compare the costs of vaccine as a proportion of total cost between the cost model and the grant. And from that comparison, what comes out is that according to our cost estimates, there's a big difference between Northern Cape and our cost estimates. So we are saying that in Northern Cape, the non-vaccine cost should be a bigger share of their allocation than what the formula for the conditional grant is saying. And this would make sense to us because maybe we've just put a larger weighting on the cost of travel, the direct cost in terms of fuel to travel around Northern Cape, as well as the time, the cost of time related to travel, the cost it takes officials to travel from Kakamas to Upton, for instance. We maybe think that takes longer than the National Department of Health think it takes when they develop the formula for the grant. But otherwise, there's pretty close relationship between our cost estimates and the conditional grant allocations. I think having one province being different like this is not a problem at all. I think it's showing sort of quite that the allocation criteria or the allocation formula for the grant is quite well informed, quite well structured. This is showing the costs of the composition of the costs as estimated by the costing model, not expenditure by provinces. These are our cost estimates. And the big costs are the vaccines in blue and the salary costs in orange. So we'd expect this variation across the provinces in the country because the provinces are different and the geography in each province is different. The density of schools, the distance between schools, sizes of schools and so on, they differ. So therefore we would expect the salary costs and the time of travel and so on to differ. Those are the big costs, the cost of time or the costs of salaries and the costs of the vaccine. The other costs are relatively small. So if you make mistakes with estimating the human resources needed to implement the grant, then you're going to underestimate or overestimate the resources required to implement the program. But otherwise, your errors are going to be fairly small as a proportion of total costs. Okay, so some points that were made to me when I spoke to health officials, or not necessarily health officials, but researchers, health researchers, academics that are familiar with this space. The 6,000 cases of cervical cancer per year, this is a number I got last year, and over 3,000 deaths, which are largely preventable through this through HPV, administering HPV vaccine, or also just reducing spread through other means, such as safe sex. It's a sexually transmitted virus, so you need to get girls before they become sexually active. You can also help prevent spread by vaccinating boys before they become sexually active. Boys don't, or men don't get the cancers associated with it, but they can spread HPV. So there is a good argument for vaccinating boys as well as girls. What they have found is advocacy and engaging and educating parents about the benefits and the absence of the side effects is critical to success. So HPV, you can carry the virus for many years without being aware of it. So, the sort of a silent killer that no one knows about and only manifests itself in your 30s or 40s or so on, when it's either too late to do anything about or becomes very expensive to address. there's just a low level of awareness about the virus and its effects. So there's a need to promote awareness, and you need to do that at the schools so you don't get resistance to schools teams coming in, and when they want to come in and give the vaccine, there isn't resistance and they are able to do their job. But 80% of reaching 80% targets generally accepted as sufficient to stop community spread. And the data suggests that we are achieving that. So the program must continue. The program itself is important, but it also needs to be supported with screening services later in life, such as pap smears at ages 30, 40, and 50, and then annually after 50. My wife is only 44. I'm not familiar with that one yet. Other conclusions we came to is focus on improving the effectiveness of the program, not trying to seek out cost savings. The program's working. We can tweak it in some ways to maybe increase coverage. If we try to cut costs unnecessarily, would undermine the success of this program. We recommended integrating the program into the school health programs. I know there's going to be work done on the school health, integrated school health policy, and hopefully this will be part of that review process, and we can look at how can the HPV aspect of that program can be strengthened, or how that policy rather can strengthen the implementation of the HPV program. We suggest running a year-long program that visits each school twice, that there are 2 cycles per year, that ensures that that teams can address gaps when they go around on the second visit. They can revisit schools that are missed, or make sure that girls that were missed in the first visit get at least one jab. There's sort of debate about the fact that whether 1 jab or 2 jabs is necessary. Some people feel that 1 jab is sufficient. There is a year-long campaign would generate greater awareness. You could also employ full-time teams that result in reduced training expenses, and then make the HPV campaign a component of other campaigns or other school health programs, integrated into school health programs, that you what am I trying to say? You run it as an integrated program with other school health activities. This is the last slide. Just some thoughts and points. As I said earlier, if anyone's from DBE, please could you ask the relevant people in your department to update the school's atlas. It's 2013 is now 10 years ago. I'm sure we could even consider using the data in the equitable share formula. I believe it's better to continue with 2 doses. As I said just now, if you have a program that visits schools twice a year, to give 2 doses, the number of other benefits that could come from doing that. The debate about whether 1 or 2 doses is needed is debated, still being debated, but it's a debate. We know that 2 doses is effective. The effectiveness of the consent forms should be explored and investigated, and whether they get the messages across, and whether they could communicate more to parents about the benefits of being vaccinated, the need to be vaccinated. That is one issue that was raised by some people I spoke to. And then, as someone who uses BAS, I have to throw this one in, that the grant framework requires a link to the objective segment, and that's fully supported, and should become remain a requirement, whether the HPV is funded through a conditional grant or is it goes into the equitable share. Provinces should still be asked to report on expenditure on HPV against the objective segment. Okay, that is the end of it from me.
Thank you, Jonathan, for sharing some of the insights and findings that came out from the spending review. And I think going through this presentation and some of the work that you did on the spending reviews shows that it's an example of government programs and interventions that actually work. And, you know, should things have been better, could have an opportunity to upscale. I mean, I think we're so used to hearing bad news and negative things about ineffectiveness of government, but I think it's such programs such as these that motivate and encourage us to sort of stay on the course. I'm gonna open up for any questions from the floor to Jonathan, or any comments or inputs on some of the work that has been shared here by Jonathan. Are there any questions? You can do so by just raising your hand and I will attend to you. Perhaps just to get things started, Jonathan, in your presentation, you sort of encourage for the grant to move into PES, or provincial equitable share, and maybe run through the integrated school health program. I just want to find out from you, do you have any concerns around whether the department or the sector will redirect these funds to other immediate priority areas, especially now that we're undergoing, you know, fiscal consolidation, fiscal austerity? Are there any, would you say there should be any concerns around that?
That's a loaded question. Yes, short answer. I'd say definitely. If you look at how the budgets was cut last in 2022-23, yeah, it is certainly a concern. I think it's unfortunate that we can't use sort of norms and standards and those non-fiscal instruments that are available in our intergovernmental system to protect these kind of expenditures. That, you know, that's the way in which it should be managed, I believe, through regulation and through requiring provinces to vaccinate girls, make it a legal requirement on them, and use that as the stick to get girls vaccinated. Yeah, unfortunately, for whatever reasons, our intergovernmental system doesn't work that way in practice, and so I would prefer it to be allocated through the PES, or, you know, phased into the provincial equitable share, because that's the way in which the system is set up. But that there's no denying that it would put that expenditure at risk, for sure.
Thank you. Are there any other questions for Jonathan? And perhaps just maybe a follow-up to that. You also, I think it was slide 10, showed the graph on the grant as a percentage of vaccine costs for all girls. And even though you said there's nothing to be alarmed about, there are variances in some of the provinces. And even though the grant is performing well, would you say there is room for efficiencies or efficiency gains in this program?
Depends how you define efficiency. You know, because you can, I don't know, you can save 10%. I'm sure you can find efficiencies here in this grant and find a 10% saving. But at what social cost does that efficiency come? You know, you might miss 10% of goals. And what cost does that incur in society in 10 years' time or 15 years' time? I think, so I'm sort of sucking my thumb, but I think the total allocation of this grant is about 200 million for something that is to prevent 3,000 deaths a year and prevent 6,000 cases of cervical cancer. Yeah, I'm not a hardcore health economist, but that ratio sounds pretty good to me.
Okay. I see there's a hand from Julia. Hello, Julia. You can come in and ask your question or any comment that you may have.
Thanks, Mbali. Thanks, Jonathan. Just two things. Is there a possibility that the vaccine itself could be made more cheaply? Local production. I don't know where it comes from, if it's imported or what is there, but is there that possibility? And then just to check, you know, after COVID or during COVID, lots of people were very hesitant about having vaccinations of any kind, and parents were not taking their kids for the, you know, the routine measles and so forth. And we saw outbreaks of that. Has that played a role in some of this, or did you not see that? Thanks.
Thanks, Julia.
Yeah, I don't know the answer to your first question, and yeah, and Bali, obviously anyone else is welcome to respond to that. Yeah, the HPV vaccine South Africa isn't the only country using it. It's internationally, it's widely recognized as a necessary vaccine. So maybe there's scope to manufacture it locally, or yeah, I don't know, find a cheaper supplier. But yeah, there's always cheaper now doesn't necessarily mean more effective. I don't know the answer to your second question, Julia, around so I'm just trying to get to the right slide where I show you the numbers. That issue around vaccine hesitancy from as a result of COVID, the numbers look fine for 2021-22. So this is the most recent numbers that I was able to get. And you know, that's from the conditional grant framework. I haven't looked deeper than that, but you know, if these numbers are to be trusted, I would say it doesn't seem to be an issue. But yeah, I welcome any other inputs on those 2 points about procuring the HPV vaccine at lower cost, and whether the COVID has had a negative impact on uptake of, yeah, or if COVID has created resistance, hesitancy, vaccine hesitancy that impacts on people's willingness to get the HPV vaccine.
Thanks, Jonathan. I'm not sure if there's anyone that can speak or perhaps assist in responding to some of the questions that were posed to Jonathan. Maybe someone that works in the space or someone from health that can assist in responding. If not, we can try find the answers for you, Julia, if there's no one here in the room. But yeah, it seems as if there's no one that can assist in providing further clarity on your question.
No, thanks.
Thanks, Julia. Are there any other questions or comments to Jonathan before we can perhaps bring the session to a close, and I'll hand over to Anita? No, Everything is clear, or clear as mud, Jonathan. Thank you so much for sharing this information with us. It's much appreciated. And this brings us to the end of our Friday webinar. Thank you for making the time to come and attend this Friday webinars. I don't know if there's anything from your side, Anita, before I draw this webinar to a close.
Yes, thanks, Mbali. Just a minute of colleagues' time to just fill in the survey, and that's it from me. Thanks, Mbali, and thank you everyone for attending.
Thank you, everybody. Thanks. Enjoy your afternoon. Bye.
Bye-bye.
Thank you. Bye.